tackling the pathogenesis of colorectal cancer. It's notoriously tricky, but we're going to map this out into perfectly clean, easy-to-remember mental flowcharts. So if you're gearing up for boards, nursing exams, or just need a rock-solid grasp on oncology pathways, you are absolutely in the right place. Let's get into it.
Here's our roadmap for the day. We'll hit the two main genetic pathways first, the APC sequence, then the MSI pathway, layer in some environmental factors, and finish up with a high-yield exam review. Section 1. Two genetic pathways, the big divide. Let's start with the big picture. How exactly does a normal colon cell just turn malignant? Well, it doesn't happen at random. It usually proceeds down one of two distinct paths. Think of it literally like a fork in the road. A normal epithelial cell takes a hit, and it's either going to go down the left fork or the right fork.
Now, keeping these two completely isolated in your mind is an absolute game changer for your exams. On the left, we've got the APC, or beta-catenin pathway. On the right, the microsatellite instability, or MSI pathway. If you try to mix these up, you'll get confused real fast. So let's walk down that first road on the left together. Moving to Section 2, the APC/beta-catenin sequence. You probably know this one as the classic adenoma-carcinoma sequence.
I want you to lock this number in your brain right now, 80%. This specific APC pathway is, by far, the most common route. We're talking up to 80% of sporadic colorectal cancers. So if you see sporadic cancer on a test, boom, your mind should immediately jump right here.
And here is your exact flowchart for that 80%. Take a mental snapshot of this timeline. The earliest event, a mutation in the APC gene. That's step 1. Later on, a KRAS mutation joins the party. Finally, to progress to full-blown carcinoma, the cell loses other tumor suppressors, specifically TP53 and SMAD. So APC, then KRAS, then TP53. That is your progression.
Let's actually zoom in on step 1 there. What's happening under the hood? It kicks off with the functional inactivation of both copies of the APC tumor suppressor gene. Normally, APC acts like a brake. It chews up a protein called beta-catenin. But without that brake, beta-catenin builds up, sneaks right into the nucleus, and stomps on the gas pedal, activating proliferation genes like MYC and cyclin D1. Then, a bit later in the sequence, the cell takes another hit, an activating mutation in the KRAS gene. KRAS acts like an accelerator stuck to the floorboard. It turbocharges tumor growth, and honestly, even more dangerously, it prevents apoptosis. It literally stops these rapidly dividing mutant cells from hitting their own self-destruct buttons. Now, examiners absolutely love testing the overarching theme here, which is chromosomal instability. If you look at these cells under a microscope, you aren't just seeing cute little point mutations. You're looking at gross chromosomal alterations and massive deletions. The genome is essentially falling apart at a macro level.
All right, Section 3, the MSI pathway. Let's reset the map entirely. Forget APC, forget KRAS. We're heading back to that initial fork in the road to check out the second major genetic path.
What's really wild about this second path is its entirely different starting point. It's driven by defects in DNA mismatch repair. So instead of knocking out a specific tumor suppressor right out the gate, the cell just loses its molecular spell checker.
And that brings us to your flowchart for MSI. Step 1, you get mutations in mismatch repair genes, usually MSH2 or MLH1. Step 2, because those genes are broken, you get mismatch repair deficiency. Step 3, every time the cell divides, tiny errors start piling up, specifically in these short, repeating DNA sequences called microsatellites.
But you know, those microsatellites, they're just the canary in the coal mine. As these repeating errors pile up, they eventually hit the really critical target genes that regulate cell survival. For your exams, remember these two major targets, the type 2 TGF-beta receptor, which controls growth, and the pro-apoptotic Bax protein, which triggers cell death. When the spell checker fails, these specific vital genes get trashed.
Oh, and within this pathway, you absolutely need to know the term CIMP, C-M-I-P, CpG island hypermethylation phenotype. This is super cool because it's not actually a mutation in the DNA code itself, but epigenetic silencing. The promoter region of the MLH1 gene gets hypermethylated, meaning it's wound up tight and just shut off. And here's the high-yield part. This silencing almost always occurs right alongside BRAF mutations. Tie those three together, CIMP, MLH1 hypermethylation, and BRAF. Okay, Section 4, environmental and dietary factors. As the old saying goes, genetics load the gun, but environment pulls the trigger. Let's look at the external modifiers accelerating these pathways. Here are the exact mechanisms you're going to see on test day. First up, diet. High refined carbs, high fat, low fiber, huge risk factor. Why? Because all that fat pumps up bile acids in your gut, and your gut bacteria actually convert those acids straight into carcinogens. Second is inflammation. Chronic inflammatory conditions like IBD or pancreatitis drastically ramp up the background risk for dysplasia and eventually adenocarcinoma. Now, time for another massive anchor point. We talked about 80% for the APP pathway earlier. Lock in this 90% for cellular environment. Roughly 90% of colorectal carcinomas overexpress an enzyme called COX-2. And why does that matter? Because this massive overexpression of COX-2 actively promotes the proliferation of epithelial cells. It's essentially throwing gasoline on the fire, driving the cancer forward, no matter which genetic path it originally started on. It is a massive amplifier.
Finally, Section 5, quick exam review. Let's put these flowcharts head-to-head so they are locked in for good.
Take a mental screenshot of this ultimate juxtaposition. Left side, path 1, the APC sequence.
80% of sporadic cases. The flow is ABC, then KRAS, then TP53, driven by gross chromosomal instability. Right side, perfectly contrasted, is Path2, the MSI pathway. Starts with a mismatch repair defect in MSH2 or MLH1, microsatellite errors pile up, and boom, target genes like BAX get completely knocked out.
All right, you've got the exact pathogenesis mapped out perfectly, but I want to leave you with a provocative thought based on everything we've just covered. Considering a staggering 90% of these cancers overexpress COX-2 to fuel their growth, how might future therapies targeting that specific inflammatory pathway rewrite these flowcharts entirely? Could we literally stop both genetic pathways in their tracks just by turning off that one enzyme? Definitely something to think about. Thanks for hanging out with me on The Explainer, and happy studying!